Thank you very much. Now I'm going to start afresh. Right, let's start. Thank you, ladies and gentlemen. I hope this will not disturb again. I'm starting again. My name is Dr. Mahapa. We are here on Zoom again. We had some problem with connectivity, but we'll sort them out. That's part of nature. We will always have problem with connectivity. It's Dr. Mahapa again, a urogynecologist in Pretoria. Initially, when I started here, to those who were here, I told them that this is a repeat webinar, solely strictly for women. It's on pelvic organ prolapse and genital relaxation. The definition of pelvic organ prolapse is descent of one or more of pelvic structures from their normal position towards the vagina. For pelvic structures, what do I mean? I mean pelvic structures like urethra, urinary urethra, pelvic structures like rectum, the vagina, all pelvic structures. If there is descent downwards towards from their normal position towards the vagina, that is called pelvic organ prolapse. While genital relaxation is loss of vaginal integrity resulting from loss of tone or strength in the muscles and ligament that supports the vagina. This is essentially meaning weakening of and dilatation of the vagina with loss of its integrity and distortion of the normal vaginal axis with the resultant loss of optimal vaginal function. What causes pelvic organ prolapse? Pathophysiology is the pelvis organs like uterus, the bladder, the rectum are supported mainly by the muscles called levator ani and the endopelvic fascia. These are the muscles that support the pelvic organ. These are connected by connective tissues which called fascia, which connect them and even connect them with the bone, which is the pelvic bone. When there is disruption or weakening through these connective tissues and muscles, that's when pelvic organ prolapse is going to occur. In women, majority women, vaginal delivery, pregnancy, and labor are the common cause of pelvic organ prolapse and vaginal laxity. So we will discuss this in relation to what is the cause of labor and vaginal laxity. Other things like trauma can also cause that, but we will not concentrate on them. The factors that make us human beings to be prone to pelvic organ prolapse is because we have evolved we are upright animals, while other animals move with 4 legs. We move with 2 legs. So gravity is always pulling us down, as the pelvic muscles are always lining this bony pelvis that you see here. The anatomy, a little bit of anatomy is needed to understand the pelvic organ prolapse. The pelvic floor, which is very important, which function is to support the function of the pelvic floor is to support the pelvic organs. If there's damage to the pelvic floor, then there's going to be pelvic organ prolapse. The function of the pelvic floor is not only to support those pelvic organs, it also assists in urinary and fecal continence, in sexual functioning, and stabilizing the joint. And it also acts as a lymphatic pump and blood pump from the lower legs upwards. We look here, you look at the bony pelvis. This is your pelvis consists of a bone like this, which consists of 2 bones on laterally, which is called pelvic bone, and wedged behind there is a bone called sacrum, which at the end you've got a coccyx, which is a tailbone. Human being had a tail, but the tail got resolved with evolution. We remain with only 4 vertebrae that forms our tail, which is called a coccyx. If you look at the pelvic bone like this, it looks like a basin. You can turn it upside down like this. Below here, it looks like a diamond-shaped structure. So we'll discuss that diamond-shaped structure when we come to that. If you put muscles on this pelvic bone, you've got muscles like this. This is the pelvic floor from below. These muscles, we've got the muscle which is in green here, ischiocavenosus. We've got the muscles which is transverse perineal muscles which run transversely here. These are superficial, but there are also muscles called deep perineal just in front of these ones. And around the anus, there is an external anal sphincter. And where they coalesce all these 8 muscles, it forms a perineal body. That's a very important structure in maintaining continence and in maintaining vaginal integrity and function. We'll come to this later. These muscles that we have seen there, if you see the pelvis, there are 3 layers of muscles. There are superficial layer, which we have seen there, which is bulbocavernosus, superficial transverse perineal muscles, and external anal sphincter, which you can see very well. External transverse perineal muscles, external anal sphincter, bulbospongiosus. But you go below them, you'll find deep urogenital diaphragm layer, which has got 2 muscles, which is called compressor urethrae, which is a muscle that compresses the urethra so that you can be able to maintain continence. You don't have urinary incontinence, and deep transverse perineal muscles. Then uppermost is the muscles called the pelvic diaphragm, that we very important muscles that keeps the pelvic organs together, which are called levator ani. Levator ani consists of 3 muscles: is pubovaginalis, puborectalis, and ischiorectalis. And coccygeus is just a muscle which is just sitting there but doesn't have much function, but it's part of those. That's why we divided this pelvic support into 3 layers, because there are 3 layers. There's the upper layer, which is the ligaments thereof are used, called cardinal uterosacral ligament, and the middle layer, the second layer, which is in the middle of the vagina, support the vagina medially, which is formed by condensation of fascia and connective tissue called acostensinias fascia pelvis. And superficially, we've got that we have seen here, which is urogenital diaphragm, that make the perineal body and support the lower third of the vagina. This is description of the upper layer, the middle layer, the lower layer. We'll see how the disruption of this is going to cause pelvic organ prolapse and genital relaxation. This condition is common among parous women. Parous women, what do I mean? Women who have delivered vaginally. They're parous. If you haven't delivered vaginally, your chance of having pelvic organ prolapse, unless you've got a connective tissue disorder that you are familially predisposed or genetically predisposed to have pelvic organ prolapse. But the damage to those muscles I described occur usually during normal vertex delivery. And it's also associated, because during normal vertex delivery, those damages, it also associated with urinary incontinence, as we discussed last month. The urogenital diaphragm, which is the most superficial layer that support the pelvic structures, if it's the gas damage, you won't only have pelvic organ prolapse. There will also be vaginal laxity, which we'll discuss later, which I added here. And vaginal laxity is the commonest cause of unsatisfactory sexual intercourse in most couples. There is the commonest cause of the vaginal carulity, which is a very embarrassing condition that women undergo, which some people call it vaginal flatus or queefing. We'll discuss queefing later. And because when the vaginal laxity occurs, the dilatation is towards the anus. So there's always sweat between the two buttocks. There's easy entry of sweat from the anus into the vagina. So the woman comes with repeated vaginal infection, being infected from the anus into the vagina. But all these conditions, although they are very important and very troubling to women psychologically, they are not talked about. Women keep them secret or they die with them because all the damage is here. What you see is urogenital diaphragm damage, which will cause vaginal laxity, which is dilatation of the vaginal orifice. The etiology of pelvic organ prolapse is chronic intra-abdominal pressure. If during pregnancy you've got chronic intra-abdominal pressure for 9 months, but there are some conditions that can cause chronic intra-abdominal pressure, like fibroid uterus, like coughing, like straining, doing heavy manual work, or some people with congenital defective genital support, which have got like Ehlers-Danlos syndrome, Marfan syndrome, patient with connective disorder will have pelvic organ prolapse. Those are the type of women that I said, even if they haven't delivered vagina, they'll have it. But the commonest culprit is pregnancy and childbirth. Because during pregnancy, there is softening of the muscles and ligaments by the pregnancy hormones. But during delivery, with those softened muscles and ligaments, they stretch, they get overstretched. And during involution, they don't return back to their normal length. So women who are doing heavy manual work, they are increasing the intra-abdominal pressure and putting a strain on these muscles, which aligns the pelvis, which are called levator and which I talked about. If you see them from below, they're like this. You put a strain on them. And we don't know the epidemiology, the incidence in different racial groups. And the prevalence will differ from study to study, which depends where do you study. But I think it's common, very common in women, black women, as is in white women. Some literature says white women has got it more, but there'll always be discrepancy because I see more blacks than whites. Some people see more whites than blacks. So there's no consensus to say this is more common in this particular age group, in the particular racial group. But what I can say with confidence is that more than half of women who delivered vaginally will have some form of pelvic organ defect. Either they'll have a cystocele, they'll have a rectocele, they'll have a urethrocoele, they'll have a uterine prolapse, or they'll have an enterocele. If they have to move the uterus, they might just have a vault prolapse. Some form will have it if we examine half of the women who delivered vaginally. In the United Kingdom, about 48,500 women remove their uterus every year. Hysterectomy is done very commonly there. And of which 15,000 of those are for vaginal procedures. Of this vaginal procedure, vaginal hysterectomies, 8,000 is because of uterine prolapse. That's a large number, which means Helen Hayes, who was the head of gynecology in Pretoria University, made a study and he said pelvic organ prolapse is the most common reason for hysterectomy in the women age 50 in a woman age 50, over 50 in white population. That's Hilton Hayes, which means women over 50 in a white population, the commonest reason why they remove the uterus is because of pelvic organ prolapse. And then I did a study in fulfillment of my Master's of Public Health, and I found that 93% of abdominal hysterectomies in that study were due to fibroids. The commonest cause of hysterectomy in Black population, according to my study, is fibroid uterus. But in that study, only 32% of vaginal hysterectomy that are done were for prolapse. So the commonest cause of hysterectomy in white population is prolapse, while the commonest cause of hysterectomy in Black population is fibroids. That's where the racial difference comes in. This is the result of my study. You can see that fibroids goes up there. About 90-something% of the patients were for fibroids. And if you look at those who did vaginally, the commonest cause of vaginal hysterectomy became pelvic organ prolapse. And this is far less than the fibroids. That's the table from Mahapa study. There are a lot of myths going out there which are not substantiated. More studies are needed to substantiate those myths. Like the thing that prolapse is common in white than Africans. We need more studies to substantiate that. Like the thing that urinary incontinence is more common in whites than Africans. We need more studies. The studies that are there are not convincing. The fact that osteoporosis, they say, is more common in white than in Black population. But you get a 70-year-old Black woman, you find that she has got osteoporosis like the white woman. We need more studies. It's because the problem with the Black population, they don't talk about these things. They keep them quiet. They don't talk much about them. So if the more they don't talk about it, the white talk very easily about them, and that's why they come forward very easily. So pelvic organ prolapse can affect any woman. It doesn't matter whether you are a beauty queen, you are a slave queen, you are a gymnast, because people used to think that only people, obese women, will get pelvic organ prolapse. That's not true. Every woman is at risk, because the risk factor for pelvic organ prolapse, they're classified into predisposing risk factors, inciting risk factors, promoting and decompensating risk factors. Let's go through them. Some people are genetically have got weak collagen, weak ligaments. Those are the people that will have pelvic organ prolapse, even if they haven't delivered vaginally. And for some people, male will have prolapse than female, of course. Those are the predisposing causes. Then we come to the inciting causes. The commonest culprit is pregnancy and childbirth trauma. Vaginal childbirth is a traumatic condition. Sometimes surgery itself, hysterectomy, if the ligaments are not attached to the wall of the vagina, they are predisposing causes. Muscle diseases and neurological disease also can incite pelvic organ prolapse to occur. Obesity is a promoter of pelvic organ prolapse. Obese people will have pelvic organ prolapse more than non-obese people because they've got increased intra-abdominal pressure, like chronic coughing, pulmonary disease. As you cough, increase your intra-abdominal pressure. Chronic constipation. Chronic constipation will lead you to, when you go to the toilet, you have to strain a lot. That way, you are straining the increasing intra-abdominal pressure, stretching, overstretching the pelvic floor, the levator ani muscles, and frequent lifting heavy objects in this era of gender equality, where men are doing same job as women and women are doing heavy job, and some recreational activity. I've realized that there's some recreational activity that women engage in that predispose them to pelvic organ prolapse. The compensating factor, of course, is age. As you grow, your tissue becomes old, it degenerates, becomes weak, becomes lax. After menopause, you've got thinning and atrophy of muscles and ligaments. Then you'll have pelvic organ prolapse. So menopause in itself is a degenerative aging condition. The pelvic floor, I look at the pelvic floor like it's a hammock. If you put a hammock like this, you put a weight on a hammock will sink downwards. That's the pelvic floor. If you put a lot of weight on the pelvic floor, it will sink like a hammock here. So in that way, you put a weight in here, it will go down like a hammock and bulge outwards. That's what caused the damage and opening of the genital hiatus. If you look at all organs in the body, the exact pressure and weight on the pelvic floor, all abdominal organs and pelvic organs, the exact pressure on that like a hammock there. And there is progressive sagging and lengthening of those ligaments and muscles that form the pelvic floor. You know, a human tissue is like a rubber of poor quality. If you've got a rubber of poor quality of 10 centimeters, you stretch it to 20 centimeters. When you leave it, it's not going to recoil to 10 centimeters. It will be about 11 or 12. It will be more than what it was before. That's what the human tissue is like. So if you put more weight on that and cause sagging and lengthening of pelvic ligaments, when they recoil, they are not going to recoil to their normal length. I always play this to show that's what the organs does when you do dancing. That's the pelvic floor. The trampoline is the pelvic floor. If that trampoline was not made of good rubber, it was going to sag down. So when you are pregnant, you do dancing, you've got fibroid, you've got coughing, that's what you are doing to your pelvic floor, is that trampoline represent a pelvic floor. Or an analogy to explain it very further. Take a pelvic floor to be like a basin. If you put fruits in a basin, depending on how much you put inside, there's always a maximum amount you can put inside the basin. If you put more, you are going to injure the floor of the basin. So you must just put enough. So if this is the basin, the pelvic floor is the basin, the fruits are the organs inside the pelvic floor. If the fruits are not heavy, they're not causing heaviness, and there's no increase in intra-abdominal pressure, then there's no problem. But we in the pelvic reconstructive surgery and medicine, we realize that once the pelvis muscles, irrespective of age or what, if these organs that are in there, which we analogy as the fruit, put more weight there, there's a bulge in the pelvic floor outwards, and there's the damages. There's between these two muscles is called genital hiatus. There's a widening of the genital hiatus, the same as genital relaxation. If the organs are normal size, the damage won't be much. But majority of women are sitting with abnormal size organs like multifibroid uterus in this woman here. You never know what's the size of your uterus until you've done a scan and realize that you've got cysts and fibroids. There's a woman who contained a fibroid of 13.2 kilograms that I've seen, which when you meet her in the street, you think that she's pregnant, but she's not pregnant. So pregnancy and diseases of the pelvis like fibroid, this woman is pregnant. This one has got fibroid, but the abdomens look the same. So the effect on the pelvic floor is the same, whether it's due to pathology like fibroid uterus or it's due to pregnancy. And childbirth will just be at the one nail on the coffin. The area of the damage is where the muscles attaches to the pelvis, at the attachment. They might detach the muscle there. There's lengthening or detachment of the ligaments that attaches, that keeps the uterus up, which is called cardinal uterosacral ligaments. The cardinal ligaments and uterosacral ligaments, those level 1 support. And the levator arm itself may be overstretched or torn. And superficially, we've got the urogenital diaphragm, which, if damaged, I've said that it causes dilatation in the genital canal and the vaginal diameter, and it causes vaginal dilatation. The perineal body disruption, it will remove that sphincter effect of bulbous spongiosis of the vagina. The vagina will become lax, and that's why the tear of the perineal body will increase the vaginal opening or the introitus towards the anal opening. That's why the woman will present with repeated vaginal infection, because the opening of the vagina is now very close to the anal opening. Of course, the vaginal wall damage will be due to damage of the muscles that cause the pelvic floor, which are the muscles that I've shown you here, which damage the perineal. The yellow portion is the perineal body that we talked about. Damage to these muscles will lead to genital relaxation. These are the ligaments that I talked about. There's a pubocervical ligament, which keeps this urethra up. There is the transverse cervical ligament, which is called cardinal ligament. Another name is sustentaculum of Bonis. is the cardinal ligament. And from the sacrum to the uterus, we've got a uterus sacral ligament, which on the side goes down outwards to go and attach to the lower part of the cervix. Those are the ligaments that keep the organs up there. If they get overstretched, they get lengthened, they get torn, then you got pelvic organ prolapse. And we never know which woman has got which disease, what it have inside. So every woman is important that she must once a year go into pelvic examination and get examined and see how your pathology is. Like you might be having things that suppose this woman has got fibroids, a fibroid of about 2 kilograms in size. What would all those thrusts are thrusting, if you've got disease there, are thrusting on the pelvic floor. Then it causes a condition called dropped vagina. It causes repeated vaginal infection because of deficient perineum and vaginal laxity, and it causes the gaping of introitus, which is damage to the perineal body. Let's explain it here. If you've got a perineal body is here, and there's a tear downwards, and tear goes towards the anus. There's a proximity of the anus towards the vaginal opening. Because of the lack of that sphincter effect of the perineal body, the opening is always lax. So sweat and feces will go easily in here. Then the patient will present with repeated vaginal infection. And again, it's important that if a woman has delivered vaginally and she's got repeated vaginal infection, they should be examined whether she doesn't have deficient perineum, she doesn't have vaginal laxity, so that she must be treated, because usually they blame repeated vaginal infection from her husband, while actually is anatomical. Those damage always also causes urinary incontinence that we discussed last time. If you've got a woman with lax perineum, with perineal damage, and some form of pelvic organ prolapse, like this woman has got a urethrocystosis. If you ask her to cough, urine will come out. If you ask her to sneeze, urine will come out. Sometimes when she laughs, urine come out. You ask her to cough, because there's a cystocele protruding here. This is some form of pelvic organ prolapse that this woman has. This condition is more common in the elderly women, which they don't talk about it. You may find that if I realize that your granny is always smelling urine, you don't know what, because when she coughs, she sneezes, urine comes out and it wets her panties. She's always smelly because of the damage that happened when she was delivering your mother, because now is your grandmother. When she was delivering your mother and aided in home delivery, there's damage that was not unattended, which a modern day woman should not allow that to happen to her. It also causes fecal incontinence, incontinence of feces. You realize that even if you wipe yourself very well, feces are always there, because during rectocele formation, if the bowel contents come from here, instead of coming out through the anus, some of them pass and into the pouch of a rectocele, and they keep on there. So always some will come out through the anus here. Most especially if there's been a damage to the external anal sphincter. No matter how hard, how clean you clean yourself when you go to the toilet, there will always be some fecal soiling, which must be looked after and be treated as part of pelvic organ damage. But the symptoms are different from any conditions. You can't say from symptomatology, this is a cystocele, this is a rectocele. Symptoms, they differ from compartment to compartment. One of the commonest symptoms that a woman will complain about is pelvic pressure. You just feel that there's pressure and heaviness in the pelvis. And because sometimes there's no vocabulary, they call it pain, they call it vavo, they call it what. And some women may realize that there's a bulge, there's a vaginal bulge. If you put a finger in the vagina, you can feel that there's a ball there. If the ball is posterior, it's probably a rectocele. If it's anterior, it's either a cystocele or a urethrocoele. If there's, or it can feel that there's something falling down. You put your finger, contract the cervix, feel that there's something is coming down here. And because it stretches the uterosacral ligament, which are attached to the back towards the sacrum, you present with chronic lower backache. And typical of this chronic lower backache is in the morning when you wake up, there's no backache. As the day goes by and you're upright, keep on pulling those uterosacral ligament, backache becomes worse. One of the things that really embarrass a woman who has got a pelvic floor damage, more especially urogenital diaphragm damage and perineal damage, is garrulity of the vagina, or vaginal wind, or vaginal flatus. When a woman stands up, she shifts from one side to another one, or she runs, there's a sound that comes out the vaginal opening, which looks like flatus. That's garrulity of the vagina. It's because of the relaxation of those muscles that I described in the anatomy, which need to be described. Some people call that vaginal wind, they call it queefing. The treatment of all that I described before, the first treatment, you don't jump on it, you observe. Is it progressive? Is it severe enough? You grade it. And if it's mild, pelvic floor rehabilitation by physiotherapy is enough. You might just win. But if it's moderate to severe, you might have to resort to surgery. If the woman is not fit for surgery, or is not ready for surgery at that moment, you can use a pessary to buy away time. Or if she's not fit for surgery because she's got other diseases, she can't stand anesthesia, she's too old, you can use pessary forever. The young ones, that pelvic organ damage more especially involve genital relaxation. The radio frequency treatment, which I'll describe later, is important. They call it vaginal tightening. Some people call it vaginal rejuvenation and other things. It's a non-surgical method of tightening the vagina. Some people call it vaginization. They've got so many names about it in the lay magazine. But the indication for treatment depends on the severity of the symptoms, or how does it bother the patient. Does it affect the general health of the patient or activity? And the correlation between symptoms and the degree of prolapse is negative. You might find that a patient with mild prolapse complains more of backache than the one with third-degree prolapse. So there's no correlation. The first treatment when you see a prolapse, if it's mild, I said, is not to jump onto surgery. The advantage of not jumping to surgery, there are methods that you can use, like pelvic floor rehabilitation, that will decrease the frequency and the severity of the organ, of the symptoms of pelvic organ prolapse. Or you can use that non-surgical method to delay, to plan surgery, to avoid surgery altogether. But because the non-surgical method, they prevent the worsening of the prolapse. They might not correct it, but they might prevent it. One of the most common non-surgical methods is what you call pelvic floor muscle exercise. You know, when you exercise any muscle, it becomes strong. So this pelvic floor muscle are called Kegel exercise. They strengthen the pelvic floor only, muscle, the exercise that directly directed at the pelvic floor. The physiotherapist has got various modalities that they can teach, individualized on each patient to strengthen your pelvic floor. I want to, if you look at this, it will make you understand very well what pelvic floor muscle exercise is, what can they do to your pelvic floor if you follow instruction of your instructor very well.
The pelvic floor is the base of the group of muscles referred to as your core. These muscles are located in your pelvis and stretch like a hammock from the pubic bone at the front to the tailbone at the back, and from side to side. They support the bladder, bowel and uterus, and play an important role in bladder and bowel control. and sexual function. If your pelvic floor muscles don't work well, you may leak when you do things like coughing, sneezing, lifting, laughing, or exercising. To stop this from happening, you need to switch on your pelvic floor muscles. To switch on the pelvic floor muscles, you need to squeeze and draw in the muscles around your vagina, as if you are trying to stop the flow of urine. Lift them up inside. Breathe normally. Don't hold your breath or tighten your buttocks. Then let go and relax the pelvic floor muscles completely. Notice as you tighten and lift your pelvic floor muscles, they tighten and close around the anal passage, vagina, and urethra. By exercising the pelvic floor regularly, you will train your muscles to...
That video demonstrates very well what pelvic floor muscle exercise can do to your pelvic floor to reduce or diminish the severity of pelvic floor muscles. The palliative method we used for those women who are very old, frail old women who cannot stand 3 hours operation, is pessaries. We put a pessary that keeps the uterus up there, keep the bladder up there, keep the rectum up there. And pessary is very good in that it can diagnose between gynecological and orthopedic backache. You know, orthopedic backache is backache that is not relieved by pessary. We must know it's in the spine. But if it's gynecological, it's a lower backache due to stretching of the uterosacral ligaments. One can confuse it that it's a bony pain, while it's not a bony pain. So if we put a pessary, alleviate the pain, you know it was a gynecological pain. If the pessary doesn't alleviate the pain, refer the patient to orthopedic surgeon. The pessary also, because they keep the organ up there, they improve circulation before surgery. In that way, preoperatively optimizing the patient for surgery. This is a pessary put in the vagina. It keeps the uterus up there for some time. But pessary must not be used routinely as a definitive method because they sit on the vaginal side wall and they can cause ischemic necrosis there because of pressure necrosis and cause lesions there. And always periodically it must be removed and inspected whether there's no lesion. If there's lesion, you must put estrogen and take the patient off pessary and so that the place can heal, but it can force a very big wound. Let's discuss this pelvic organ prolapse compartment by compartment. We divide the pelvis into 3 compartments: anterior compartment, middle compartment, and posterior compartment. In the anterior compartment, we've got the urethra. If a urethra prolapse, it causes a urethrocoel. We've got a bladder. If a bladder collapses, it prolapses, it causes a condition called cystocele. If they both prolapse, it's called urethrocystocoel. In the middle of the pelvis, you've got only one organ, is the uterus. If it prolapses, it causes a uterine prolapse. If the woman has removed the uterus, the vaginal vault, which is the roof of the vagina, can prolapse also. It's called vault prolapse. When the vaginal vault prolapses, the intestines also follow. Find that inside the prolapse, there are also intestines. It's called enterocoel. In the posterior compartment, we've got the anus there. If the rectum prolapses, we've got the rectocoel. We discuss them by compartment by compartment. I must say that the commonest form of prolapse in any woman is a cystocoel, the anterior compartment, followed by the uterine compartment, middle compartment, and the least is the posterior compartment. Let's start with anterior compartment. We have got a defects that can cause a condition called hypermobility of the urethra. Urethra becomes hypermobile. You know, a female urethra is about only 4 centimeters long, while a male urethra is about 12 to 15 centimeters and it coils around. So that's why this female urethra is prone to have incontinence because it's not so long. And it spans the anterior 4 centimeters of anterior vaginal wall. To test whether you've got urethral hypermobility, there's a test which is a very cumbersome test that we used to do. They call a Q-tip test, where they put a cotton wool through an awake patient inside the urethra and ask her to strain. If it makes an arc more than 30 degrees, we know that she has got a urethral hypermobility or she has got a cystoscele. We don't do that now. You can do it by just looking. This is putting a Q-tip test. You put a cotton wool stick inside the urethra. You ask the patient to strain or to push. And if the cotton wool divate more than 30 degrees, you know that is a significant urethral hypermobility. That's called Q-tip test. We don't do it anywhere. I don't encourage anybody to do it. You can just look. You look at this woman. She's like this. You ask her to strain. You look at the urethra with your own naked eye. You'll see what the urethra does. It faces upwards there. You can see that you can estimate that's more than 30 degrees. That's not more than, and then there is also a urethrocystocyst coming out here. You don't have to, I think it's very uncomfortable to be put something inside the urethra while we are awake. You can just look how the urethra deviates. It deviates upwards more than 30 degrees. We'll be able to estimate how much this urethra has deviated. The hypermobility is caused by urethral hypermobility, is caused by the damage to the ligaments that keep the urethra to the undersurface of the pubic bone. It's called pubourethral ligament. And also this muscle that I talked about, which was part of the middle portion, or part of acrostendineous fascia pelvis, which is called sphincter urethrae. It becomes lax. It causes urethral hypermobility. And with that, you might up there on top of the urethra, you've got a bladder. If your bladder prolapse, it's called a cystoscele. The main support of the urethra and the bladder is pubocervical cervical fascia, the fascia that attaches the cervix to the cervix and to the bladder. If there's damage to that due to childbirth, then the bladder will prolapse. And essentially what's happening is a herniation of the anterior vaginal wall through the wall. And because of this weakness, it causes a central cystoscele. We'll describe a cystoscele later when we see. And you can see the cystoscele. It might be mild, which is called first degree. If the anterior vaginal wall is visible from the introitrus, in summary, the first degree, if you can depress the perineum and see pink, you must know you've got first degree cystoscele. If the bladder and the anterior vaginal wall extend outside the introitrus, you push and the bladder comes outside. That's second degree. If it prolapses beyond the introitrus, beyond the hymenal caruncle layer, then it's third degree. If the full length of the bladder is outside, that's the worst form of prolapse. I want to demonstrate you so that you can see what prolapse is here. You see the bladder is sitting here. You see later when the bladder prolapses, it becomes the leading cause. It goes down and come and protrude through the vagina. Let's demonstrate it further this way. We're looking here, the bladder. If you pull it here, it will pull the uterus along, but we classify it according to which structure is the leading structure. This is the bladder. This is grade 1, first degree prolapse. It will still be within the vaginal opening, but it doesn't go up to the opening. Second degree, it goes up to the opening. Third degree, beyond. And if the whole thing is outside, is the worst form of prolapse, because normally the bladder should be just below the uterus. If the bladder descends downwards, and you can even feel it like a ball, put a finger in, a woman put a finger, feel it like a ball, then that is a cystoscele. Although it's sometimes very difficult for women to differentiate which organ is that, but on examination, the examining doctor can easily see that. When you look at this woman, she has got a rectocele and a cystoscele, but the predominant damage is the bladder that bulges as he pushes. If the bladder damages, usually said that or doesn't only come alone. It also comes usually with a, if it comes with a rethrocele, definitely you're going to have occult urinary incontinence. If you do a speculum examination, you'll see that there is damage to paravaginal wall. If you look at here, after the speculum examination, the lateral vaginal wall are collapsing. That's paravaginal wall damage due to damage to that middle layer, which are called acostendinous fascia pelvis, which attach the middle part of the vagina to the pelvic side wall. So if you look at the speculum, they're the first one to do. So during repair, you must attend to that also. And if you pull the speculum outward, there will be a bladder, urinary bladder following you. That is a cystocele. And this woman has got grade 2 cystocele. The more the grade, the more difficult is the repair. If you turn your speculum upside down, you don't have to have a zip speculum. You can use a fiber speculum. You can see that the anterior vaginal wall is collapsing, and the posterior one is collapsing mildly, as a rectocele, but the cystocele is predominantly following you. That's how you diagnose a cystocele. This I demonstrate for the medical doctors who are in here, because majority of the medical doctors I know they're here, they're looking, and they see these things every day. They see it more than us. It depends on them. They refer only those that they think they need to refer. They are the ones that treat them. This is because of the level 1 damage. Level 1, I said, cardinal uterosacral damage, that Delansky's level. And the causes is precipitous labor. Beware of precipitous labor. Precipitous labor, by definition, is labor that starts and ends within 1 hour. A woman will find herself praising herself, I just started having pain now. Within an hour I was delivered. There's so much damage that has been done on you because of that fast labor. Chronic cough, heavy manual work, and hysterectomy are the commonest cause of those compartment 1 damage. The middle, I said, we divide the pelvis into the anterior, middle, and posterior compartment. The middle compartment, I said, there's a uterus in it. If anything that prolapses here, it will be a uterus prolapsing. And the brutal prolapse, I've got an animation for it here. It's very nice. Uterus is here. If it prolapses, it descends downwards through the vagina to come out through the vaginal opening. And we can also grade it depending on the extent. If the entire uterus is outwards, that is called presidentia. That's the worst form of uterine prolapse. If we start it again here, slowly, if it's still within the vagina like this, it's level 1. Majority of women who delivered vaginally, which I said, they've got some form of pelvic organ prolapse. They've got this level 1. Once it peeps through the vaginal opening, it's grade 2. Grade 3, grade 4 is the worst form of prolapse. Unfortunately, I don't know why, I find people presenting late. If a person presents with grade 4 prolapse like this for the first time to a doctor, why has he been doing? It's because he has been keeping it secret. He doesn't tell the women. And because if you've got a genital laxity again as part of the damage, it becomes precipitous. You prolapse very easily. This shows that if the genital orifice is still intact, it can help other women as well. Normally, the genital orifice is not so precipitous. And I think the aim of this webinar is to educate, to talk to the grannies out there, those who have got 3, 4, 5 children, but don't they have these particular things? You must look for the vocabulary how to approach them, because they might just shout at you if you just talk as if you're talking with your age mate. But these people are sitting with these things. They don't know what to do. You discover them when they come for other diseases, and you find that they've got a maximum descent. Usually you should find them when it's descending halfway to the hymen, grade 1, or at the hymen, grade 2. Grade 3 and grade 4 is unpardonable. You must know that person hasn't been seen for quite a long time. And there's this myth that if you have removed a uterus, you won't have a uterine prolapse. I've said that most especially people who are obese, even if they had hysterectomy, the vagina can come upside down into a condition called vault prolapse, depending on how hysterectomy was done and how your tissues are. Some people have got very soft tissues, so that even if you do hysterectomy, how fast you can do it. sometimes in their lifetime, the vagina is going to come upside down like you take a pocket out. It's going to come like that. That's vault prolapse, which is also can be repaired if it does happen. And I said in the posterior commandment, we have got a rectocele, which is descent of the anterior rectal wall into the vagina. The anterior rectal wall descends into the vagina. And also common in women who delivered vaginally, or women who have got second or third degree perineal tear during delivery. They were not cut episiotomy, they got torn, they were sutured, but not sutured properly, because third degree and fourth degree tear must be sutured in here. They were just sutured in the labor ward, and it doesn't heal very well. And people who have got chronic constipation, and women, the modern women who are ascribed to the issue of gender equality, who are equal to men, who can do as many jobs as the women can do, then the uterus, the rectum can prolapse. As it prolapses there, the feces must come out through the anus. Some of the physical matter will pass and then lodge in that pocket there. That's why these people will always present with fecal incontinence. No matter how hard they wipe themselves when they go to the toilet, there'll be some soiling, always some soiling of feces there, because they don't evacuate all the feces when they go to the toilet. Or they've got another sign which is called tenesmus. Tenesmus means a feeling of incomplete evacuation. He goes to the toilet and evacuate, but when he stand up, he can feel that there's still something inside here. Sometimes she has to put a hand into the vagina to push this feces which are in this pocket here to come out through here. This when she has got a rectocele, which is chiefly a hernia in the posterior vaginal wall, secondary to the weakness in the rectovaginal septum. There is a fascia there called fascia of Dunn-Valley, which if it's weakened or torn, it causes a rectocele. And the best way to examine it is rectovaginal examination. Another common posterior compartment defect besides the rectocele is perineal deficiency, which is tearing of the bulbar cavernosus superficial transverse perineal muscles, and as they coalesce to the perineal body, they cause a perineal deficiency, which I'll discuss as part of a vaginal relaxation. And you've got perineal descent, sagging and funneling of the levator ani with the perineum, such that the anus becomes the most dependent part. If you're standing up here, the anus should be higher than the vaginal end. But if the anus becomes dependent, it means that that basin that I described about, that hammock, is sunk downwards, and the person presents with difficulty in defecation and tenesmus, that feeling of incomplete evacuation. You look at the rectum, rectocele, look at the rectum as demarcated here. It goes and come out through the vagina, and the feces can lodge here. It can also be graded like all others. If the rectum is still here, grade 1, grade 2 at the introitus, grade 3. This is a rectocele, but by just looking at the finger, woman might not. A clinician or a nurse must be able to see this and tell them that this is a rectocele, because it's dilatation of the posterior vaginal wall. And this rectocele is caused usually by excessive pushing during childbirth. I always had women praising themselves. I pushed 4.5 kilograms. This is not something to be proud about. If you push 4.5 kilograms, baby, it means you have damaged your pelvis more. There are various methods to correct this rectocele, like posterior colporrhaphy. Because of chronic constipation of feces lodging inside the rectocele, some people think that you can get a temporary relief by stool softeners and laxative and pessary. They have no help, because they'll help you only for that defecatory. If you've got overt rectocele like this, is good, it can be repaired. But majority of rectoceles are covert, they're hidden. It's only on speculum that you find that up there's a rectocele. And the woman was always complaining of difficulty in going to the toilet, feeling of incomplete evacuation. And when you do a speculum, you can find a covert rectocele, equity. And the repair of all prolapses when they protruding through the vagina is an indication for repair. And when it is progressive, we see it this year, next year, after 6 months, is worse than it was before. It's an indication for repair, which means it could not result to non-surgical management. When it is contributing to abnormal vaginal access, which is disturbing the sexual function of the woman, and or you find it during vaginal hysterectomy as a primary, you can do it. But one thing most important, the best choice of treatment is the first one. If the first treatment that you choose is the worst one, you'll never correct it again, which means the best choice is the first choice, which means the first choice must be the best choice. So you must thoroughly assess what the damage is and go and correct the damage. If you miss the damage and correct it wrongly, it's whatever, you can never discorrect it. This is surgical management, because the aim of the surgery is to relieve or improve the symptom of prolapse and the symptoms that are associated with lower urinary gastrointestinal tract. In some cases, very rarely, women who are not sexually active, very old, obliterative approach, which is called colpothlysis, which means actually abolishing the vagina altogether, close it altogether. There's no vaginal canal. It can help, but that's very rare in very old women. In some women, the aim of repair of pelvic organ prolapse is attempt to restore the normal vaginal anatomy and to improve sexual function. That's all. You can't come and complain about that. Either she herself has realized that sex is not as it was before, or the partner has told, but the partner don't tell much. She herself has realized that. And if it's self-diagnosed, is the better. And as I said, the first choice, the best choice. You must prepare the damaged site only. And the goal is vagina of the normal depth and the width and the axis. That's aim of repair. You must make the vagina of the normal depth and the axis. The surgical repair for vaginal prolapse can be hysterectomy, or anterior repair. If there's paravaginal wall repair, you must do a paravaginal wall repair, or repair of cystocele. Rectocele will be repaired by rectocele, enterocele will be repaired by repair of enterocele. If it is a post-hysterectomy, repair the vault. The commonest one that is done by women these days, because it's advertised in Lay magazine, is what you call perineurapy for relaxed vaginal outlet, which they call vaginal tightening. I'll touch it a little bit here because it's more pertinent. If the vagina is torn, the perineal body towards the anus, you will find that women realize that it doesn't tightly ensheath the man's penis. They go for vaginal tightening, so that after tightening, it becomes better. And this woman like this, they always have the repeated vaginal discharge because of the proximity of the anus. And when they bath, water can easily go inside here with dirty things. But if it's well tightened, it becomes healthy. But sometimes we find that it's vaginal laxity with rectocele and cystocele concomitant there. But if she goes and repaired properly, then the hygiene is done properly. The sacrocolpopexy is a long procedure. It takes me about 2.5 to 3 hours to do one sacrocolpopexy. It takes a long time. If a woman has had hysterectomy and she has got vault prolapse like we've seen, you have to go abdominally, go and attach that vault with a mesh to the sacrum of the bone. You attach a mesh to the vault and dissect beyond the peritoneum subperitoneally to attach it to the bone so that you can suspend this. This is something that is the treatment of choice for a well-fit woman who still want to maintain sexual function. But if she's not fit for surgery and she does not is not interested in sex anymore, you can do what you call sacrospinous fixation, which it deviates the axis of the vagina. You can do it vaginally. You suspend the vault of the vagina to the sacrospinous ligament. You can do it unilaterally or bilaterally. It depends. But those are women who are not interested in sex anymore, with elderly women. Another condition that is very pertinent, which goes hand in hand, I said I added it here because it goes hand in hand with vaginal relaxation, is pelvic organ prolapse, genital relaxation, which I said for the purpose of this discussion, I'll call it genital relaxation. Well, actually, if you go and Google it, you might not find it, but if you say vaginal relaxation, you'll find it. This condition, not easily discussed in the couples. It causes decreases in genitopelvic sensation during sexual intercourse and negatively impact the sexual life of every woman. It's a dilatation of vaginal opening or vaginal canal. And with the dilatation, you lose those convolutions that we call orgn, which also in menopause you lose them. Thus, you lose that frictional effect that usually happens during copulation. And it reduces the frequency of vaginal wind and vaginal discharge. I've said vaginal discharge is due to proximity of the anus towards the anus with the vaginal relaxation. Then it reduces the self-esteem of a woman. If a woman feels that he's like that, the confidence is diminished and the self-esteem is diminished. Most believe the partner can tell her that things don't look like before when you were still courting. And this thing is not things that comes now. They've been there for years. How have they been treated in the olden days, our forefathers? They had this commonest form of treatment, the treatment of genital dilatation when there is vaginal opening and canal dilatation was polygamy. If the woman has delivered 4 or 5 children, now she has got perineal damage, pelvic floor damage, she has got genital relaxation. The man goes and looks for a younger one who doesn't have these diseases. The second one also delivers 3 or 4 children, suffer the same fate. She goes and marries the third one. If we look at the polygamous marriage, the ages of women, they go down as the number of women increases. And more often you find that the age of the third wife is more or less the same age as the firstborn of the first wife. Why do they go like that? Because to counteract the effect of vaginal laxity on men. But you can't do it now. You can't do it now. If you do it now, you cause more problem because women nowadays, they don't want to share. Not to say older women wanted to share, they had no choice. Women have got rights these days. But is it not the cause? I put a question mark here, but I don't have evidence that it is like that. Are the men not the rate of infidelity that we see, cheating, that happens? Is it not because they are trying to counteract vaginal laxity, like their forefathers used to have polygamy? Why are they now men, older men, going for younger children? They call them blessers. Why are they so common? Is it not because of vaginal laxity? I don't have the answer. That's why I answer question, because I haven't read anywhere. I don't find any study that says that men of these days, they go for young girls because the older ones have delivered vaginally. They have got vaginal laxity. Now they're going for stiffness. But if you look at the logic, it might be illogical because what else can an old man go to a young girl? Because there's nothing they can discuss. Psychologically, they are much different. It's only going for that. So I think if you want to prevent partner infidelity, exclude this as part of the cause, because otherwise the treatment, which I'm saying we likely to be wrong, but I'm saying it in the extent of infidelity that happens now, might be a way to counteract the effect of vaginal laxity. So partner infidelity does not only lies with the partner, it also lies with the wife to prevent that partner infidelity. So I think that's my thinking. Because if we look at vaginal delivery versus cesarean section, the baby doesn't come out through the vagina. It comes out through the abdomen. So the vagina remains intact. But during vaginal delivery, the baby, with a head of about 10 centimeters in diameter of the head, is going to come through a vagina of about 3.5 to 4 centimeters diameter and dilate it to 10 centimeter length. And expect when involution occurs, when tissues goes to normality, it must go to a normal. And I have said that a human tissue reacts like a rubber of poor quality. If you dilate this to 10 centimeters, probably when it recall is going to recoil to about 5 or 6 centimeters. It won't recoil to 4 centimeters, which initially was. We want to see this podcast that demonstrate very well when the baby comes to the vagina during delivery, a 10 centimeter head diameter going through here. And more especially when the head, the process called internal rotation, when the shoulders are going to rotate here, you're going to find that it dilates it more and more and more. And when recoiling, which is a process called, when the tissues are going to recoil to normal position, the process called involution is not going to be like that. That's why during delivery, that's why home deliveries are discouraged, because if you deliver unattended or home delivery, there's going to be a tear towards the anus. Definitely, the weakest point will be towards the anus. But if you deliver attended, there will be a cut. They will cut it, trying to divert the tear, extension of the tear towards the anus, so that if there's any extension of the tear, it shouldn't go towards the anus. And secondly, to reduce the amount of resistance that will be offered by the opening, they do a cut which is called episiotomy. And I always tell the midwives that episiotomy, you don't cut it when the head is crowned. There's this, I don't know who said that. You don't cut, you cut it if you decide that this head I'm going to cut episiotomy, which I think every woman should do, to cut it before there is stretching of the muscles here. Once you can wait for the head to stretch, to crown, and the muscles are stretched, and you are cut it late, the damage is already done. So before the head can even crown and leave the perineum, cut the episiotomy and deliver the head. Because if the muscles can tear by themselves, sometimes they tear inside the skin, you don't realize them. And if they tear inside the skin, you don't realize them, you don't see them. The only thing that is going to happen with vaginal laxity. And the patient is going to come with queefing, repeated vaginal infection. So there's going to be perineal damage from normal vaginal delivery, which without episiotomy. If you look at the perineum like this, you remove the skin here. If you remove the skin, you find those transverse perineal muscles here. If you don't cut episiotomy, it's like this, you don't cut and divert it that way, you're going to have this muscle tearing. If you look at very well here, this muscle is torn here. It can be torn both sides, but it's covered by the skin. So you don't see that they are tearing, but actually they are causing weakness in the perineum. That's why they cause perineal deficiency. One method that's for nurses and midwives and community health workers, family physicians, that when they examine this, when you examine a woman, you look at the labia minora. If the labia minora should span from the frenulum of the clitoris, where the labia minora ends, that's where the orifice must end. If there's any extension from the where labia minora ends, you must know there has been trauma here. There's some form of pelvic floor relaxation. Because when the tear occurs, it occurs from the vagina towards the rectum. It can only be rectal mucosa, can involve the muscles, it can involve the anal sphincter, can involve the anal mucosa, depending on the degree. If you look here, the tear extended up to the external anal sphincter, which means this woman, if it's not repaired, she's going to present with anal incontinence or fecal incontinence. These are the different grades that you can see. If it's first degree, it's only the mucosa that is torn. This you can switch in the labor ward. Second degree, the mucosa and part of the perineal muscles, superficial perineal, transverse perineal muscles, and deep transverse perineal muscles, with or without levator ani. This you can switch in the labor ward. But from third degree to fourth degree, you've got to go to theater, because there the tear involves the anal sphincter. And anal sphincter is the only muscle that the anal sphincter muscles, the muscle that is constantly under contraction tone. If you are sitting like this, your anal sphincter is closing. That's why feces don't come out. So once you cut the anal sphincter, they retract and hide far from the area of tear. So there's no way you're going to fish them out in the labor ward with the patient who is awake. You need a patient who is relaxed under anesthesia to go and fish them out and suture them. Otherwise, if you suture it in the labor ward, you end up with anal incontinence and fetal incontinence. And the worst form is where the rectal mucosa is also cut. In that way, the anus and the vagina is more or less the same thing. If it's not repaired, really is catastrophic. Which means 3rd degree and 4th degree must be repaired in theater. If a woman present with perineal laxity and ask her, where did they cut you? Did you tear? You say, yes. Where did they suture you? In the labor ward. You must know that because they didn't get the anal sphincter correctly, because you must go to theater. When you go into theater, you must go and fish laterally deep next to the ischiorectal fossa. You get the anal sphincter there, you suture it in 3 or 4 stitches and make sure that you oppose them. Then you can suture the other area upwards. You can correct this 4th degree tear into a normal tear. The woman who has had an occult 4th degree tear, which vagina goes up to here and was sutured in the ward, will end up with a vagina with escaping large introitus and with or without fecal incontinence. And that way, we have to go and do, it's a very big operation, to go and redo it and do what you call vaginal rejuvenation, which means restructuring the vagina anew, because those muscles are healed there and the sphincters are deep there. It's about 1.5 to 2 hour operation to do that. And the commonest cause that they'll come with now, they will not blame them. They'll come because there's coital dissatisfaction. And I said that it must be the wife, the lady who discovers that. Because it's a very difficult topic to discuss at home. Not many couples will just sit down and discuss the quality of sex that they're having. Very few. Because the reason are many, just from mere modesty. You can't tell your lover that you don't look like before, man. You can't tell your lover that you don't look like when we were still young. You've now deteriorated. It sounds like abusive. It sounds psychologically abusive. So you keep quiet. Even if you love her, you are modest, you won't tell her. But as I said, a man make a plan. If there's sexual dissatisfaction, the man will see what to do. Because when you look at a man as it grows old, the degree, the quality of stiffness of the erection, it diminishes with age. And ejaculation needs more friction as the man ages. So you need a tighter vagina for the men to ejaculate. That's why they go for younger girls, bless us. Even in a man, the G-spot stimulation and orgasm, it needs friction. So if there's vaginal laxity, there's less friction and less orgasm. And with a man, again, the latency period between ejaculations increases with age. If a man could ejaculate twice a month, a night, a day, when he was still young, as he grows older, can ejaculate or have erection once in 2 weeks, 2 days, once in a week, once in 2 weeks, until he becomes once a month. As he goes very old, it will just come once a year for 2 minutes and then it disappears. So the tightness is needed for satisfactory sexual, for both partner and a woman. I've got this picture for a man, the man's life cycle is like this. You look at it and you understand it very clearly. These are the ages from 30 to 31. You see this horse can jump. That is the type of a boy, when you wake up in the morning, your urine, you can throw it up there, 4 meters away from you. But as you grow older from 31 to 40, you see that this horse is getting tired a bit. Up to 50, well, it can still push. From above 60, it can push, but with a little effort. From 65, you really have to hit it with Viagra to push. From there, 65 to 70, even if you hit it, it doesn't push much. So this is how a man behaves. So from 50 onwards, when the horse does not put his head up, that one is going to need more friction. These are from 41 to 50, 59. These are people that goes for young girls. These are the people, silly young men, but you can't blame them. As women, we should just counteract that by preventing the damage that occurred because of vaginal delivery, which we did because we love them, and we, of course, for the cosmetics and aesthetics and the beauty of any genital, we still have to do vaginal cosmetic surgery, because a woman is one person who can do anything for aesthetic. For the hair, you do aesthetic. For the eyes, for the boobs, for the breasts, for the abdomen, and for the genitals also. Women they like them beautiful. They like them aesthetic. The reason for doing this is for the aesthetic and for functional purposes, because you don't want to have a woman, this woman, they say after childbirth, I'll remove the uterus. I won't have to menstruate, I'll just be fine. But I've told you that even after you have removed the uterus, if your connective tissues are bad or you're due to menopause, you can have a vagina coming up inside out. And if it comes inside out, it'll be there inside out. You can see this one. It means all day is inside out. It's dry, it's scaly. The mucous membrane, which is there, which was columnar, now it has changed. It underwent metaplasia, is now keratinized squamous epithelium. And every time, it's always outside. If you don't talk about it, you can't get bursary, which means the problem with it is that if there has to be engagement in sexual intercourse every day with the husband, or every evening before the foreplay, they must push it back inside here and do whatever they're doing. And then maybe because the patient is not upright, it might stay there for the rest of the night. But the following morning, when she stands up and start walking, doing daily chores, coughing, as women, as I said, they do a heavy manual work, as it does a manual work in an upright position with gravity pulling down this evasion of the vagina is going to occur again. And the treatment of that evasion, I've already described it, is either to sacrospinous fixation or sacrocolpopexy. Many women are staying with these things out there, and we discover them very late. The treatment is cosmetic vaginal surgery. This is a video. You can see that this woman, even if she can push, nothing can happen because it's been well repaired. This topic is not, as I said, is not discussed very well. Another topic that really disturbs women with genital relaxation is queefing, vaginal flatus, discharge of air or wind from the vagina, which is odorless, because although it looks like it's coming from the back, the air from the back has got an odor. Discharge from the air from the front has got no odor. It's not flatus per se, but it can be embarrassing, especially if you are sitting among people, there's air coming with sounds, or in the case during intimacy or changing position. And that's what needs vaginal reconstructive surgery. Sometimes this air, woman can feel that it's going to come. It's like it can try to stop it there, but you won't stop it. It will come. Something will come out. And you can feel that something seems to be coming out of me, and you don't know where to run to, but something is coming out, and that thing is air that has been trapped there. Just this one to testimony or the teaching that this woman is teaching about this air.
Have you ever struggled with queefing or farting out of your vagina? It could be very embarrassing. Lots of clients that practice yoga very often tell me that it happens when they're coming out of an inversion or when they're coming out of a position with their legs on the walls. Nobody wants that to happen. It can be annoying and embarrassing. Why does it happen though? So very often it can happen for three common reasons. The first one is pelvic floor weakness. So of course I recommend that you go to a pelvic floor therapist. If you have pelvic floor weakness, it can cause laxity around the tissues that open and close the vagina and allow air to get in. And then when you come out of an inversion or a position or out of down dog, air can escape and cause that embarrassing farting noise. The other reason why it may happen is if you've had a scar or you've had childbirth and have had a tear or episiotomy, and that scar tissue decreases the contractibility of that tissue, which also prevents you from closing optimally, which can allow air to get in and then embarrassingly escape when you come out of an inversion or down dog or legs up on a wall position. And the third common reason.
Did your vagina just fart? This is known as queefing, the involuntary passage of air from the vagina. It happens because during certain activities such as running, yoga or sex, air can enter the vagina. Since the vagina is a collapsed muscular tube, the collapsed walls can trap the air inside, which is then released when you change posture or when something is introduced into the vagina. The air vibrates the vaginal tissues on the way out, causing the noise that you hear, which sounds like a fart.
All this plus others that I've described is attended to, and now there's a fashion that women come because women are associated with beauty, with a procedure called perineoplasty, which is plastic surgery of the perineum. And they give names that are not scientific, like vaginal tightening or vaginal rejuvenation. There's nobody who can rejuvenate a vagina. It's just a name that they give. And this field is called female genital cosmetic surgery. It encompasses procedures destined to change the aesthetic and the functional aspects of women's genitalia. It focuses on the functional and aesthetic. Aesthetic means beauty, appearance of the genitalia. I've said that women, for any organ, they'll go for aesthetic. Nose, mouth, ear, everything. They like aesthetic. And if there's mild damage, there are various methods, radio frequency and laser treatment, that can cause vaginal tightening or vaginal rejuvenation. But major damage like prolapses will need surgery. So this rejuvenation, it tightens the muscles of the vagina and the canal, vaginal rejuvenation or perineoplasty, and prevent that repeated vaginal discharge, which I said the cause is because of the proximity of the anal orifice, and minimizes queefing. I must say minimizes. You can't stop queefing. Even a woman of normal vaginal, in some position of sex, there will be queefing. So queefing that's disturbing is when that happens in the positions, even among the people, you start to stand up as and that you're queefing. But you can't stop queefing in sex. There's no way. Every woman in some form of some position, one day, one another, there will be a queefing one day. That's not something that should be attended to. What should be attended is excessive queefing, that you are sitting with your friends, you start to stand up, now air comes in, they think you have passed the flatus, then you haven't passed the flatus. And also this procedure enhances sexual satisfaction of both, and it's called orgasm booster. There's also a procedure which is done together with this, which is called an O-shot. Go and Google it, O-shot, shot, S-H-O-T, which can be done together with the female genital cosmetic surgery to boost the orgasm. And the cosmetic look and self-esteem of any organ will always, woman will want, which they call improving sex by design or designer vagina or virginization, which is just names from the lay magazine, because there's no virginization. You can't, once a person is not a virgin, you can't make him a virgin again. But those are just names that people use in female cosmetic genital surgery, where the morphology and the functional of vagina is enhanced and the look and sexual classification. And some people call it intimate surgery, or vaginal rejuvenation, or cosmetic vaginoplasty, or aesthetic genital surgery. They call it with many names, meaning the same thing. And it's promoted mostly by the public, not by health, because they don't kill this thing. The target organ for female genital cosmetic surgery is mons pubis. They do monsplasty. If a woman has got excessive mons, they can do monsplasty. If they've got excessive labia minora, they can do labiaplasty, labia minoroplasty. If the clitoris is large, they do clitoral hood retraction. If the vaginal orifice is large, they do vaginoplasty. Or if vaginal orifice is too tight, they do fentoplasty. If the perineal body is lax, there's vaginal laxity, they do perineoplasty. The vaginal orifice and canal, vaginoplasty, fentoplasty, and perineoplasty are the commonest that the people present with in female genital cosmetic surgery. And then, as I said, that it all boost the self-esteem and sexual gratification. A woman also wants to perform like young. Nobody wants to be called a woman. If you want to irritate a woman about 50, call her granny, call her gogo, call her, she'll be very much offended. While a man, the more you call her, say she's old, she feels more good. She doesn't want to be called young. But the woman wants to be called young. The same way with genitals. A man is proud if she's got bigger genitals. A woman is proud with smaller genitals. So women always want to be small. If you want to call a 50-year-old woman and say, yeah, girl, yes, young girl, she feels very great. She thinks she's still young. But you call a man of 50 and say, boy, and then you offend that man. That's how we are made. Men are proud of being old and women are proud of being young. So women wants to perform like young girls always. And that's what is made for them. That's why this labiaplasty surgery, which is aesthetic surgery, is so much promoted, so much in the lay magazines that women go for it. Especially in the African, some of the subtribed in South Africa, young girls are encouraged to pull their labia minora while young. That process, they call it hukweva. They're encouraged to kweva. So when they are old, they've got enlarged labia minora. And now they are going to the change room in the spas, at the gym. They are embarrassed they don't look like others. They put on the underwears that do not cover them, like they put on G-strings. This labia minora are so enlarged that now they want to look like others. That's why they go for labia minoroplasty, which is called labiaplasty, in order that they can look like others. While it's the procedure that they were encouraged by young for reasons that are unscientific, that it causes sexual gratification. I don't believe that is like that. Or some people, without even pulling them, they're just naturally having enlarged labia minora. They're called megalabiae. If the labia extend beyond the fold between the pubis and the vagina, it just means that labia is too young. So people come for labia minoroplasty because they are putting on bikinis and the G-strings cannot put them in. They disturb them when they swim. They disturb them when they can't go to the beach, and people will wonder how they look like. So aesthetic is very important. Of most important is during sexual intercourse, they disturb, although they say the old women will say that that's how you keep a man. You must, if during sex, this is a vaginal sauna, like during vaginal sauna, they'll be pushed inside here and become very heavily painful. And because during foreplay, they cannot be wet, they become very heavy and women cry because of that. That is what women come for, usually for vaginal tightening, which is a common procedure among women who care about their relationship with their spouse. And I say that this symposium I said for women, I assume only women are listening to me. Any man who's listening to me is listening at his own risk. The women must do self-introspection and self-appraisal and make sure that you are on top. Because partners are often mute. They don't talk about it. They just look for alternative. An alternative is infidelity with all its negative effect. Negative effect of infertility, another child might be born outside. HIV and AIDS might come in. There's also financial consequences because you can't have a Nyansi without spending money on it, because even this day, sex is commercialized. Once somebody has got a Nyansi, you must know he's spending a lot of money. So women alter the shape and the body parts for aesthetic and functional purposes, which we don't shun upon. If you've got an introitus it's damaged, the best thing is to go and do vaginoplasty so that it can look better and function better. I said that if it's mild, it's not much damage, it can be done in the room with radio frequency or with laser. I use radio frequency with the process called 360. This is how it's done. me explain it better. With ultrafilm tracer, this radio frequency waves. We put the probe inside the vagina like this. Then it hits the radio frequency waves, which are electromagnetic waves. They hit the vagina here. They promote angiogenesis, formation of new vessels. Suddenly, you've got more vessels forming. And if the vessel form, there's more blood flow to the vagina. So there's no more vaginal dryness. And the nerves also, they proliferate. When the nerves proliferate, there's more sensation. And thereafter, with time, the thickness of the vaginal wall increases. If the thickness increases, what happens to the diameter? The diameter diminishes. And you can change the probe. In some older women, you find that even the labia majora are shrunken. They've got wrinkles. And they want them to be full. Then the radio frequency can also do that on the labia, protecting the vestibule, and makes a full become full. So that's how aesthetic can be. This is the same one that is being done on the face. People do Botox so that they can alleviate the wrinkles on the face. You can alleviate wrinkles there. Labia majoroplasty is usually is done if there's labia majora. The plastic surgery thereof is usually done for aesthetic and lifestyle adaptation, because on your lifestyle, people nowadays, women don't don't put on dresses, they put trousers and skinny trousers. And the commonest thing people come for labioplasty is because they want to avoid a condition called camel toe. Because of this skinny, if you've got skinny jeans, the pants that are tight, if you go to the shop now, all pants are tight fit. You find that if they've got camel toe, when they've got skinny tee, the contour of the genitals can be seen even when she's working in the mall, and that she doesn't like. And sometimes with the camel toe, the hypertrophy of the labia majora become asymmetrical. You find that you've got camel toe, which is the other labia is more than the other, and you're wearing a jean, walking around, and it's seeing. Women don't like that. That's why they come for that cosmetic surgery. This condition is called a camel toe because it looks like a toe of a camel. That's why they call it camel toe. So women should go for it to prevent that camel toe. They go and reduce the labia majora size so that they can look normal like all other and put jeans. It's not good that when you see people who are wearing, then you have got to cover yourself because you've got to do something that you don't want people to see. That's why there are some jeans, there's some undergarments that says they cover the design size that even if you've got camel toe, they will not show it up. They written say hello to camel no. So this is what we discussed today. Basadi, the Bible tells us that when a woman being was born, the first sin was invented by a woman. After they've eaten this apple given by the snake, they realize that they are naked. But they don't explain how far naked. I mean, if you are naked, the whole body, you must dress the whole body. Which means it doesn't matter whether you haven't dressed on the legs, whether you haven't dressed where. If you haven't dressed on the waist, on the genitals, then you are naked. Which means nakedness means here. Which means this is the most important organ in the body that even Adam and Eve realized. We can leave everything be heated by the sun and naked, but you can't leave this area. So even now, you women, you can't leave this area unattended. This is the area that you must look for very seriously and care for, more than you can even look after your face, because this is the area that from the beginning, Adam and Eve realized, no, this is the area that is important. In conclusion, ladies and gentlemen, although this condition seems to be very simple, they are very complex. It improves medical care and life expectancy of women. Women live long, so we'll have more of these conditions, and they'll put financial burden on individual and the state. And we can't stop vaginal birth and say all people must deliver by cesarean section. So the advent of vaginal tightening and vaginal cosmetic surgery is an in thing that women should utilize to counteract the effect of vaginal birth. Women don't want to deteriorate. If you can see women, they're very entertainers. If you can see women by entertaining, usually at a wedding, but for sure, those women, they are not quivering, they don't have pelvic organ prolapse, they don't have incontinence. If you see women doing this, they don't have Ladies and gentlemen, it's not good for a woman to be secret about that, Kati, to discuss it among ourselves. And you know, I don't know what it's our language. It's easy to discuss it in English, but in our language, we don't discuss it. Why? Who said that our language, if we call things by a spade, is vulgar? When you say spade, you must be a big spoon. It's not like that. I like the Basotho Bagamashweshwe, the Southern Sothos. They have evolved beyond this. Maybe it's because they're the first one to accept Christianity. They've criticized, they've analyzed it very well. They call a spade a spade. They don't call a spade a big spoon. Even their songs. I was impressed by one song, which has got much teaching, which most people would not think it can be sang. Listen to the song, you will realize. Thank you very much, ladies and gentlemen. This is the end of the seminar. I hope I've shed some light unto you. And I think as usual, we will have to take some few questions. I'll appreciate if it can be more discussions than questions. I'm now allowing you to unmute yourself and if you've got any contribution, there are a lot of medical doctors and nurses and allied workers here who can help. This is not me teaching, it's us discussing. So any contribution, subtraction, addition, or question and clarification. If it's a question and clarification, I don't have to be the one who's answered. Anybody can answer it. Ladies and gentlemen, we're open. We will open by raising your hand. Let me see gesture. My hand is up. Let me see. I want to do such that reaction. Recognize reaction ke hand. Mahale. Unmute.
Thank you. Good evening, colleagues and Dr. Mahapa. Thank you very much for again coming back with this
Thank you.
very important topic. You know, there is, you know, gender-based violence, and most of it is, you know, against a woman. So my worry is that when are women going to rest? I mean, from the first sin, as we said, in the garden, they were punished because they collaborated with the snake.
Mm.
Then they had to carry the pregnancy for 9 months while the man is busy elsewhere.
Mm.
They had to go through this, you know, the elevator, I mean, they said it can stretch 200% during the second stage of labor and cause all those damages. After delivering all these people, now everything down there is damaged. Now they must go and pay for repairs, surgeries, and all these things. Now they are being attacked by men and everywhere, you know. They are still be treated like a snake. I mean, black people, if they see a snake, they won't rescue it. They'll try to kill it. So I just don't know when the women are going to rest. And one other thing as health practitioners, we need to be aware of what you've been teaching us today. Because most of the older women, as you said, they will not speak about this. I mean, I had a 82-year-old woman who came, she had a severe constipation, and then she used a spade. But when everything came out, the anal mucosa was torn, causing an anal fissure. I mean, that's very painful, anal fissure. So she came to consult for an anal fissure. She didn't want to undress, but I told her, no, she must be relaxed, because when I examine women, I've got the lady I'm working with there, you know, just to accompany them and so they can feel much better. Also to protect myself in case, you know, I might be accused of whatever, you know, by patients. At least if you've got one of the ladies you're working there in the room, it's much better.
It's called chaperone. That person is called a chaperone.
Chaperoning. Yeah. So then we had to look at the tear there. And then she was with the daughter, I think her last born. She undressed, but she was not easy. Then she said, no, these people must go out. She wanted to say something. The daughter and the lady. Then she said, look, there's something which is happening down there, which I don't want anybody to know about. So that's when I checked and I realized, no, the womb actually is protruding through the vagina. And nobody knew about it.
And she wants to keep it secret.
Yeah, but I was lucky that I was looking at the anal area and she just said, no, she wanted to inform me. She told me that nobody knew, nobody in the family. She's the only one who knows it. And then I spoke to her for quite a long time, counseling her. And then eventually, after some time, she agreed to go to Bara. And then they showed the daughter how to put, what is the ring, the diaphragm.
The pessary.
Yeah, pessary. They can't, you know, I mean, operating at that age. She's no more sexually active. Yeah. And she benefited from those pessaries, you know.
Yeah, that's a surgical method. If she's not fit for anesthesia, very old one, the surgery itself is more dangerous than the prolapse. You give a pessary, you look after pessary well, she can live a near normal life.
Yes. So was it not for the anal fissure? This thing was just going to continue forever.
Yeah, you see them more often when they come to consult for other conditions. But this one, they keep it secret. I don't know why there isn't. Maybe women can tell us why you keep it secret, women. The next one, I don't see any hand here, but my grid here doesn't show everybody, you know. Maybe just talk, because I won't be able to see whether you've got your hand on or what. Because you go to reaction there, you can see what reaction it is. Without any hand, I'll assume, because I think I've made you to unmute, you can unmute yourself and just talk, because I don't see any hand here. I'm trying to increase my grid here. It cannot.
I have a question.
Hello, my dear. What's the name first? Because I don't see the name here. I can't mention it.
My name is Guipelo.
Guipelo, how are you?
I'm great. Thanks. How are you? Thank you so much for this. It was a wonderful talk and great discussion. More are definitely needed. I'd just like to ask a question with regard to if you experience severe weight loss. I'm talking about weight loss of 50 to 60% of weight loss and how
Weight loss.
weight loss. So you were previously about 140, you are now 70, and how that such a loss can affect your genitalia, and if you would benefit from these surgeries that you covered earlier today. Any of these treatments would help, because the genitals would definitely not look the same from how it was when you were 142 when 70.
Okay, there are two ways. In the presentation, we said the obesity is one of the promoters of genital prolapse. But if you lose weight, it is good that you won't have genital prolapse. But weight loss, in the last few slides, I discussed camel toe, where women come labia majoroplasty. If you got weight loss, gain weight, you might maybe have a camel toe. That weight loss might just benefit you there, but I think weight loss has got a positive effect, a good effect in that you won't have genital prolapse, pelvic organ prolapse. So I'll encourage you to lose weight. The radio man is, I'm muted to now, the radio man is disturbing. Okay, ladies and gentlemen, thank you for the comment, Dr. Zoli Mutlante.
Sorry, Dr. Mahapa.
Any of the colleagues, one of the nurses, any of the Tendani,
Another question.
Let's listen to that question.
Yes, and then I have a few questions. Ne?
Tendani.
Yes, can you hear me?
Yes, Tendani, introduce yourself.
Yeah, no, it's fine. I did unmute.
Yes. Fine.
All right. I have a few questions. So, first question, I want to know from your experience and then further knowledge. It's a myth. In ancient times, they used to say that women used to give delivery while they were standing, and as if they're opening legs. And that one has been approved to be a proper way of giving delivery. But then ever since now, women have started to lie down while giving delivery. That's another cause of certain complications, which we are discussing now, of prolapse. I don't know what's your take on that.
Look, if you deliver standing, gravity will help you. The chances of delayed labor, whether there's mild cephalopelvic disproportion or not, will be minimal, because mind you, those women were delivered by traditional midwives at home. But that is the one that is causing worse damage, because it's going to be, like I've said, precipitous labor. Labor does start and finish in 1 hour. Is one that causes more damage than the gradual labor. So actually, those are the women that Dr. Mtlandu was talking about that will keep secrets more. There used to be more pelvic organ damage during that time. But if it's lying down, the dilatation is gradual, and there's attendance, there will be episiotomy. Although there will be damage, you can't prevent damage. It will be minimized. I wouldn't recommend that anybody should deliver standing now at the moment, because you can't have a good lithotomy while standing. I think I've answered.
Yeah, it's clear. And then the second one, and then I heard you talking about that women, they are lifting and now they are working heavily, like unlike before. And then I wanted to check, like, as you are saying that they are lifting, like, are you also considering or also including the lifting at the gym as well while they are exercising with an aim of losing weight and also building the thighs?
No, I'm saying women do everything that a man does in this day age. There are women who are called bodybuilders. Those women that I've shown there, the thin and the other one. There are women do everything that a man does. If you go to any factory, If a woman wants a job there, he says any job, whether it's a job for loading a truck or unloading a truck, you'll find a man and a woman doing the same job there. That's why I said some heavy jobs are meant for men. This issue of gender equality must be looked at very seriously, because some jobs that are masculine, they've got negative effect on women. You'll find women working, carrying heavy objects with men, because he's hired for that job and he does that job. You go to gym, as you have said, find this woman says, I want to be a bodybuilder, and he's a bodybuilder. But there's going to be negative effect that in that context that I said so.
Okay, and then the last one, it's on the radio frequency. Does it also treat rectocele or prevent on the women who can just come regularly while they are still young?
Pardon? Come again?
Radio frequency. Does it also prevent the risk, not to treat, but maybe to prevent or to minimize the risk of rectocele?
Literature, I haven't met it around that time, but I don't think you can just treat something in anticipation, because that you mean is prophylaxis. If there's no damage, then you treat so that damage must not be there. You must cause constriction. The literature, I haven't met that it minimizes, it prevents the occurrence, but it treats, if it has happened, it treats it. But as far as prevention, I haven't met about it. I don't think it will be a good thing that a woman with a tight, good vagina will give a radio frequency in anticipation for any case she gets vaginal dilatation. If she doesn't get it, what? What if she gets vaginal constriction? I don't think it will be scientifically and clinically correctly indicated treatment to treat somebody who doesn't have a disease. It's like to say, shouldn't we give everybody antibiotics for any case she gets infection? You don't give everybody antibiotics for any case she gets infection. You give once she has got infection. I think I've answered. Ladies and gentlemen, I know that I see men are answering. You know, Dr. Mhlanhla, what you said, that women, they sit down when these things are, even on this seminar, they don't talk about it. They're keeping quiet. They will never talk about it, women. But this symposium was made for women to raise their awareness there.
Women, can you come out, please?
Can I just say something with regards to that, Doctor? It's
who's that? Who's that? Name first.
Guipilo again. It's very difficult topic. I'm only 38, and I can assure you that even at my age, it's taboo to mention certain things. Even the vagina is very hard to just say a vagina, and it's a very difficult conversation to have with men as well, whether it be our partners, be it our healthcare providers. It's extremely difficult. A lot of education has to be done on that. Just
according to you, you think it's a topic that must be entertained to prevent things openly, or it must just be kept like it doesn't exist among couples?
It needs to be spoken about on a very large scale. There's a lot of education that needs to be done. There's drives, especially in the rural communities, but not just, like I'm saying, I'm in the city, I'm 38, but even amongst my age mates, this is not something that is just the saying vagina. We have cute names and things, so we are never going to discuss its diseases, even amongst my peers. So it's a lot of work that needs to be done, a lot.
You know, the reason why I put this genital relaxation inside is because after the presentation of genital prolapse, pelvic organ prolapse previously, I met a lot of women, and I work with women, and me and them, we discuss them very easily. And they touch this a lot. They touch this a lot on one-to-one basis. That's why that woman, that Dr. Mhlanhla had said, these people must get out of here. I want to talk to you. With the clinician, they are very easy. They come flowing very well. They touch this. So I said, okay, let me include it here. But among the public, people don't touch it. That's why I said the clinician and the healthcare workers would then done, the allied, the family physicians should come here, because with them is easily discussed. But women among themselves, co society, they don't discuss this thing co society. This thing was until go society, go social club.
But somebody mentioned that it's picked up when we are at the clinician, but not for that issue. It's if on questioning and examination you pick it up, it will not be the main reason we are at
They
the
won't
doctor.
volunteer it. Yes.
Yes.
That's
To
Dr. Glenn too says so.
Yes.
Ladies and gentlemen, I think it was a nice, we are closing the year this year with this topic. December, there's no webinar. As usual, I don't know what will be the webinar for January. We'll start the webinars in January. These are monthly webinar. I'll do 11 webinars, every webinar every month. Focus mainly on female health as a urogynecologist. So I wish you all a Merry Christmas and a prosperous New Year. We'll meet in January in good strength, and God bless you. Thank you.
Thank you.
Thank you so much. Appreciate you.
Thank
Thank you.
you.
Thank you.
Thank you. Appreciate
Thank
it. Thank
Bye-bye.
you.
Colleagues.
Thank you, Dr. Saywell. Merry Christmas to you. Thank you. Bye. Thank you.
Zola.